Namaste and good morning everyone. Today we have gathered here as a part of our regular CME and the topic for today is MRI Basics. In a regular practice we keep on seeing MRI, CT scans, X-rays, but somehow we miss certain points. So we have kept the topic MRI Basics today so that we don't miss the common things, and for this I would like to invite Dr. Shishir Kumar to enlighten us about this topic. Thank you.
Good evening, everyone. I'm Dr. Shishir Kumar and today, this evening, I am going to enlighten you about the MRI basics. So we should start. MRI is an imaging modality that uses non-ionizing radiation to create useful diagnostic images. So here we want to say that there is no ionizing radiation, so there will be no radiation hazard for the patient. Only and the magnetization is used for generating the images. There are MRI pulse sequences. There are a lot of protocols. We go through that and then we generate images of the patient on our machine. So there were some starting with the history. So there were some Nobel Prizes given for the invention of MRI, starting from 1944 to Rabi for physics. The most renowned one was by the Paul Lauterbur and Peter Mansfield, which was given for physiology and medicine for MRI technology in 2003, the latest one. This was the first MRI image which was taken of a human being by Raymond Madian Minkoff and Goldsmith in 1977, 3rd of July. Magnetic field strength of the MRI machine, the SI unit field is Tesla. Previously it was measured in Gauss. 1 Tesla is equal to 10,000 Gauss. So Tesla is the new SI unit for magnetic field strength, which we call like 1.5 T or 3 T of MRI machine. So there are two basic principles of magnetic resonance images are based upon. It's basically a hydrogen imaging. So what we do, any atom which is having an extra nuclei will generate image. So in our body there is water in abundance. So the hydrogen atom out of that we use for generating the image. So that's how the MRI imaging can also be called as hydrogen imaging. So this is a cross section of an MRI machine. We have this gantry. This is a MRI scanner. Here are the radio frequency coils. The patient is laid down and then the radio frequencies are given. They excite the hydrogen in the patient. It gives out the signal which is again received by the gradient coil, which is transferred to the computer machine, and by the mathematical Fourier transformation, from the mathematical equation the images are generated. So basically what we all as clinicians know that this are T1 images, these are T2 images. Now we want to understand what are these T1, T2 images are. So before that we have to understand what is TR and TE, that is repetition time and echo time. So we have given there is a sequence. So we have given the frequency to the patient, and there is a certain time when there is an echo in the patient, which is again taken by the machine. So that's the time to echo, and how many times we are giving repetitive these echoes, that is repetition time, 2 or 3 or 4, whatever, those are the repetition times. So T1 images, there is short TR and short T, that is less than 1000 milliseconds and less than 45 milliseconds, and for T2 there is long TR and long time to echo, that is more than 2000 seconds and more than 45 milliseconds. Why MRI? Why should MRI should be used? So there is no ionizing radiation. image acquisition is done in multiple planes, that is sagittal, axial and coronal. Superior soft tissue contrast is there. Some angiographic images can be obtained without the use of contrast material. Advanced techniques such as diffusion, spectroscopy and perfusion allow for precise tissue characterization rather than merely macroscopic imaging. Functional MRI allows visualization of both active parts of brain during certain activities and understanding of the underlying networks. Risk of iodinated contrast allergy is gone off. So in descriptive terminology, which we are going to T1 में hyper intense है, T2 में hypo intense है. So we are going to understand that when there is a high signal intensity, it is hyper intense, which is white. Then there is intermediate signal intensity, which is isotense, which is gray. And then there is low signal intensity, which is also called as hypointense, which is black. What are the disadvantages of an MRI machine or as such MRI images? It is more expensive than a CT machine, not easily available, it's not easily available everywhere. It takes longer scan time. Patient comfort can be an issue. It is claustrophobic and noisy. It is subjected to unique artifacts. It's not safe for the patients with some metal implants, pacemaker and foreign bodies. And MRI contrast has nephrogenic risk. There are multiple sequences when we do a MRI, which you all have heard of. There is T1 weighted images, T2 weighted images, post-gadolinium, which is post-contrast. Then there is flare, stir, diffusion, GRE, proton density, MR spectroscopy, MR angiography, MR venography, CSF flow study, MR perfusion, and DTI. We are gonna take every sequence one by one and understand how it can be useful for our patients. So this is a image of a axial scan of head. All are axials. This one is a CT picture. You can see bone very properly, and the gray matter is gray, and gray matter is slightly brighter than the white matter. This is a CT image. This is a T1 weighted image where gray matter is gray and white matter is white. When we see a T2 weighted image, here the CSF is white, CSF is black over here in the lateral ventricles, then cortex is a bit whiter and white matter is darker. In flare images, though the CSF has been suppressed, is black, but the it's just like a CT thing. Its cortex is a bit brighter than the white matter. We will understand the differentiation. So what things are dark on T1 weighted images? Edema will be dark on T1, tumor will be dark on T1, infection will be dark on T1, inflammation will be dark on T1, hemorrhage will be hyperacute and chronic will be dark on T1, and anything like calcification or flow voids will be dark on T1. What will be bright on T1? Fat will be bright on T1, subacute hemorrhage will be bright on T1, melanin, protein rich fluids and paramagnetic substances will be bright on T1. These are T1 weighted images. We can see the subcutaneous fat is bright, the fluid is black, white matter is white and cortex is grey. Then we come to T2 weighted images. What are bright on T2 are edema, tumor, infection, inflammation, subdural collection, methglobin and late subacute hemorrhage. So in addition, we can understand the T1 weighted images are primarily used to locate the anatomy of the structure, where the pathology is, what is the location of the pathology, to understand the anatomy of the structure. And T2 weighted images are used to look for pathologic stage, where is the pathology and how it looks. MRI is all about location and tissue characterization, what type of pathology is there and where it is located. CT is just for the location and somewhere we can comment on the characterization of the tissue, but MRI is more sensitive and specific for tissue characterization. What is dark on T2 is low proton density, calcification, fibrous tissue, paramagnetic substance, protein rich fluid and flow void. So these are three axial sections which were taken at same levels. First one is T1 weighted images because the subcutaneous fat is bright. T2 weighted image because CSF is white, and again it is a flare image where fluid is being suppressed. So CSF, the normal CSF have suppressed, and can you see this is our subependymal nodules? So they are better visualized on a flare image. So this was a patient of tuberous sclerosis which was having subependymal nodules. Which scan best defines the abnormality? On T1 weightage image, subacute hemorrhage, fat containing structures, anatomic details are best defined. T2 weighted images, edema, demyelination, infarction, chronic hemorrhage are best defined. On flare images, edema, demyelination, infarction, especially in periventricular locations, are well defined. So here in MRI, when we talk about a hemorrhage, how a hemorrhage will look, how can we age the hemorrhage? So the whole process is defined by the aging of hemoglobin, how it's transforming. That's how we are getting all these pictures from the hyperacute, acute, early acute to the chronic stage. So hyperacute stage is less than 12 hours. On T1 and T2, on T1 weighted images, we will get a iso intense lesion. On T2 weighted image, we will get a bright lesion. For a acute hemorrhage, for which the age is like from 12 hours to 2 days, we will again have iso intense lesion on T1 weighted image, and same will appear dark on T2 weighted image. The early subacute stage, when it is from 2 to 7 days, T1 weighted image, it will look brighter and a bit darker on T2 weighted image. Late subacute is from 1 week to 2 months. It will be brighter on T1 weighted image and bright on T2 weighted image. Chronic, which is more than 2 months, again it will be darker on chronic on T1 weighted images, and the rim will be darker on T2 weighted images. Conventional inversion recovery. So if we again move from normal T1 T2 weightage images, so we again, you might have heard about stir image and a flare image. These are inversion recovery sequences. What we understand, there is a tissue, we think it's a fat, so we will give a signal to suppress the fat. If that lesion is suppressing in the signal, it means that tissue is fat. If it is fluid and we are suppressing the fluid, if it get the signal of the lesion gets suppressed, so it's a fluid containing lesion. That's how we understand and proceed. So stir, the full form is short time to inversion recovery. In here what happens, we give a signal to suppress the fat. Stir is there to suppress the fat in the pathology. So how we'll understand, this was a T2 weighted image, and there was an occult fracture which was not visualized on MRI. In scaphoid on lunate, marrow edema was not visible. But when we did stir and we suppressed the fat, the edema was properly visible in scaphoid and lunate, and because of an occult fracture which was not visualized on T2. That's how it helps in seeing the pathologies which are not visualized on the normal basic protocols. There was this patient which came into our clinic. The patient came with a swelling in the subscapular region on left side. We did a sono for this patient, small part. It was hyperechoic, which was representing fat. Yet for this session, we did separate studies. So we did a CT. CT was looking hypodense lesion, which was well defined in left subscapular region. When we did the Hounsfield density of this lesion, it was coming fat density. We knew it was fat, but still we went ahead with the MRI images. So T1 it was bright, T2 it was bright, but when we did the stir images, the fat got suppressed because we're suppressing the fat signal. So this was a lipoma. So again we are talking about flare sequence, which is fluid attenuation inversion recovery, fluid attenuation inversion recovery sequence. So what happens here, we are suppressing the fluid. यहाँ पे सर हम fluid को suppress कर रहे हैं ताकि जो pathology है वो अलग से delineate हो जाए. the flare images are always there to confirm which we are seeing on T2, whether what we are seeing is just a normal fluid or it is a pathologic fluid. If it is a pathologic fluid, it will be bright on flare also. So this image, we are seeing the transmental sign, which was not visualized on T2, but when we did a flare, we can see a transmental sign. Patient came with complaints of seizure. This was a focal cortical defect. Same here in this, on a T2 image, it appeared normal, but when we did flare, we can see small hyperintense signals. So it turned out to be embolic infarcts. T2 was normal, but when we suppressed the normal fluid, the pathology became more delineated. Then we come for diffusion weighted images. So what we are doing in flare, we were suppressing the normal water, normal density, which was having Brownian movements. So normal fluid will always have Brownian movement within, so it gets suppressed. But in diffusion weighted images, what we are doing, we are going to suppress everything else and just locate where there is more dense water, like in pathologic stage, cytotoxic edema. We know in stroke, what happens, there is lot of water accumulation in the cell. So we are gonna see that. This is how a stroke will look on a diffusion weighted image in the ACA territory. So it will look brighter on we will see flare, we will see T2, there is pathology, and then we will do diffusion weighted images. If it's bright, then we will say that it's an acute stroke. But yet we have to wait. We have to do a ADC map also. We have to do a ADC map also. If that thing which was looking brighter on diffusion weighted image becomes darker on a ADC map, then it's true restriction. This is true restriction, because here we are seeing if it doesn't get suppressed on a ADC map and it's brighter on that, then it means this lesion is having normal fluid which is very hyper intense. These are like heavily T2 weighted images, so that's not in pathology, that's T2 shine through effect, which is an artifact. So just to tell that this stroke is showing true restriction, hyperacute strokes are always showing true restriction. So we have to do ADC map also. These are all coming in stroke protocol. This is how, sir. This is a diffusion weighted image where there is hyperintense signal, and when we are doing a ADC map, it becomes hypointense. It means that this is a true restriction and true pathology is there. There is nothing which we are seeing as an artifact. Then there is gradient recall echo. When we are seeing this is a sequence which we will use to look for a calcification or hemorrhage to confirm. So this was a flare image where we see a slight hyperintensity, but when we we did our GRE for the same patient, we see it become darker. The thing is called as blooming. So on GRE we see blooming. Calcification and hemorrhage will bloom. So whenever we are suspecting hemorrhage or any calcific thing, so like oligodendroglioma, which will have a calcific foci, so we will do a GRE and we will pick up the calcification or a hemorrhage. So this was again, there is something called as SWI images. Separate machines have separate things. So when we are seeing on a flare, we can see just the hemorrhage. When we did a GRE sequence, we see like more other foci of hemorrhage, and suspectability weighted image is more specific for hemorrhage. So we are saying as in this big hemorrhage, there are other small multiple hemorrhagic foci. So GRE and SWI are used side by side. If possible, we should always use SWI images. But it's basically Siemens वाले GRE देते हैं and Samsung वाले SWI देते हैं, तो it's very brand का issue है उनका कुछ. So again we are talking about MRA and MRV. There are two types. MRA we can do without contrast also. MR angiography and MR venography we are talking about. So MR angiography we can do without contrast, because there is something called as time of flight thing, where we are mapping the flowing blood in the brain. So this is the TOF MR angiography. This is circle of Willis. So any like in the patient of a stroke, we can see if there is an occlusion, there is a thrombus, it can be very well picked up. and MRV is always done with contrast. So this is a MRV image, so where we can see a venous occlusion. We are talking about MR perfusion. So place where I have worked, we had something called as a stroke protocol. When patient used to come with a clinical symptoms of a stroke, so we had code blue. Code blue means patient came in the emergency and he will again taken to the CT room. A CT will be done if there is no hemorrhage and if there is some hypodensity, patient will be put in MRI. Flare will be done because we have 4 hours to salvage the brain. So there is a core of stroke, and then there is hypoperfused tissue around, which is penumbra. So we have to salvage that penumbra thing because that is salvageable tissue or salvageable brain. So there is something called as diffusion perfusion mismatch. So here we see on a diffusion weighted image that this shows restriction. When we talk about diffusion, we talk about restriction. When we did perfusion, there was this restriction, but else then this was also brighter, this whole area. So this was hypoperfused brain. We, by giving the thrombolytic, we can save this part of brain. So if there is a mismatch, that's good for the patient because there is a part of brain we can save. So this was the mismatch, means this area in blue could have been saved by thrombolytics. If there is no mismatch, means it means that the area which is showing the core, it's already gone, we cannot save it. There is no further need of a thrombolytic. So again we are talking about MR spectroscopy. MR spectroscopy, here we see the small metabolite or electrolytes. These are some are like myoinositol, choline, creatinine, glutamate, and this is a neuronal marker, and acetyl aspartate. So what we get a graph, we put a voxel like this on the lesion and we get graphs like this. So there is a peak at, like there is this line. So at 4.3, 3.0 we will have a peak for each metabolite which is given from first of all. So when we do that, we get a graph and we can say that what is happening in that lesion. So this is lipid. When we get a lipid peak, it means that there is a brain destruction. When we get a lactate peak, it means that there is anaerobic glycolysis. When there is a Na, that's a neuronal marker. So these is like a whole properties when we are seeing. So MRS, how we are gonna use it? Like when I am saying that this lesion could be neoplastic, like how in MRI we give, but what it is, whether it is neoplastic, whether it's a glioma, whether it is an infection. So we put MR spectroscopy voxel over there and it tells whether it is infection or whether it is a glioma. So we need less need of biopsy. Eventually we will do biopsy, but like first stage of biopsy, we know that this is a neoplastic. Again, the diffusion tensor imaging we are talking about. So this is something like diffusion weighted image where we were using the Brownian movement of, we were exploiting the Brownian movement of water. So as we know that there is the normal fluid have isotropy. Isotropy means water can travel in anywhere. So that we were exploiting and we were using diffusion weighted images. Diffusion tensor imaging when there is anisotropy in the water molecules, like the water is flowing into a direction. So the water will move in a direction. So those are white matter tracks. So from right to left, from up to down, that's how around the myelin water is moving. So we are exploiting that property of water, the anisotropy of the water, to bring the images. So this is some type of image we will get on our picture. So these are the tracts and white matter tracts. It's also called as MRI tractography because we are imaging the tracts. How we gonna use this? If there is a tumor somewhere lying, if it is very near to the tract or if it's engulfing the tract, we will not dissect the tumor. We will refrain from that because again patient will generate deficit after removing that tumor. fMRI we were talking about, that is functional MRI. Functional MRI is things we do a MRI while the patient is performing something like a click of the thumb or playing some music with his hand, so that we can see the motor cortex or anywhere. So how it's gonna help us. So if there is a tumor which is less than 2 centimeter near to that cortex, so we will not operate that tumor, because there are high chances the patient will, after the operation, patient will develop a deficit. So all the functional areas will be we can visualize on functional MRI.